Good afternoon. This hearing will come to order. Before we begin, I'd like to ask for unanimous consent for members of the Washington delegation to participate in today's hearings, should they be able to attend, and without objection, so ordered. Today, the subcommittee continues its oversight of the Department of Veterans Affairs implementation of the Electronic Health Record Modernization Program. We have reached a critical juncture in the implementation. We are now a little more than 4 months from the plan go live in Spokane, Washington on March 28, 2020. Over the last 18 months, many activities have occurred in support of this effort. I commend the VA and thank you for being here, for your approaching this as much more than an IT upgrade. It is an opportunity to modernize the way the VA provides health care to veterans and has the potential to improve healthcare outcomes throughout our nation. However, many questions remain about VA's readiness to operate the Cerner Millennium system in a clinical environment. The outstanding punch list of configuration, interface development, testing, and training does not fully express just how complex and necessary each of those elements are. If any of those items are not completed in a timely manner, it will be very difficult for the VA to bring the system online in a manner that does not compromise patient care. In just a couple of weeks, the VA will need to pass through a major milestone, the first of 2 integrated validation events, or dry runs. These events will essentially allow the VA to assess how the new system works and if the VA is ready to go live. I know that Cerner has been engaged in testing individual modules, but we need the entire integrated system to be tested so that it can be used for training. We cannot make the same mistake that the DoD did in its IOC, where it tested on a mocked-up system. As I've said since I became chair of the subcommittee, the most important thing is that the VA get this right, not that it hits an arbitrary deadline. I'm concerned that the VA has not given itself enough time to fully test the system, nor have they allowed time for all users to adequately train on it. I think the full complexity of this project became apparent when the VA decided to roll out capabilities in 2 different sets. While it certainly makes it more digestible to take 2 smaller bites, that does not alleviate the pressure of infrastructure, staffing, and community access concerns at manned grand staff. Those issues need to be resolved or mitigated for a successful rollout to occur. This subcommittee needs an honest assessment of where things stand with readiness at the individual facilities. There are also joint decisions and actions that the VA and DoD must make together, including data strategy and rules governing the connection to existing systems. I believe that if the VA and DoD had invested more fully into joint governance, these potential pitfalls could have been mitigated. Yet, here we are right now and must take the necessary steps to address these issues moving forward. I'm also concerned about the level of communication between the VA and our veterans. While having an integrated health record someday will improve veteran care, the process of implementing it will be far from painless for its users. As I learned when I traveled to Madigan Army Medical Center earlier this year, there were a lot of patient care pain points, including referral management, pharmacy access, and patient communication. I still have not seen enough information from VA to understand how these issues have been addressed for the VA go live. Before us today, we have accountable officials from each level of implementation. I am pleased to have the Deputy Secretary joining us today. As the lead accountable official on this program, I especially want to hear your perspective on the state of readiness. We also have officials representing the clinical operations of the VA, the program office, and most important, the facility leadership. I look to our facility leadership as the last bastion of patient care and safety. Both Dr. Fisher and Dr. Tadich have been observing the day-to-day process of EHRM implementation, and I want to hear your perspectives on your facilities preparations. I expect each official at the witness table to provide an honest assessment of where things stand and what more needs to be done. While there are no certainties in any IT implementation, there should be no surprises due to lack of preparation. We will judge whether this program is ready to meet the needs of clinicians and veterans by what we hear today. I thank all of you for being here, and I look forward to your testimony. I would now like to recognize my colleague, Ranking Member Banks, for 5 minutes to deliver his opening remarks.